Today I'm presenting the evaluating of the relationship of treatment dose and sleep efficiency in veterans enrolled in a cognitive behavioral therapy for insomnia program at the Oakland Behavioral Health Clinic. Veterans and insomnia is a huge problem. Veterans in the U.S. military that receive honorable general discharges under honorable conditions are considered to be veterans. They're eligible for health benefits through the VA if they served over 6 months on active duty, and nearly 9 out of 21 million seek healthcare services from the VA in the United States. If they had a combat status, it's determined by whether they served in a war zone, theater of conflict, received combat medals, any hostile fire, or imminent danger pay for being in harm's way. The background of the problem is the prevalence. PTSD, or post-traumatic stress disorder, affects over 500,000 Iraq and Afghanistan veterans alone. PTSD presence leads to insomnia, and it is the most common complaint among these veterans. 20% of all suicides in the United States, average about 22 tests per day, occur among veterans. Any clinic visit for insomnia associated is a risk for suicide. The veterans' insomnia rate is about 24 to 54% versus the general population rate of about 10 to 22%. Contributing factors to the problem include predisposing, precipitating, and perpetuating circumstances of insomnia that occurred during service. 79 to 87% experience some comorbid post-traumatic stress disorder with sleep disruptions. Some of these perpetuating factors include energy drink consumptions, trying to stay awake during service, and then of course PTSD that's related to insomnia, needed to readjust from their military to their civilian life and sleep schedules when they return home. Additional background problem is the effects on health and function. Ongoing irregular sleep pattern leads to adverse health effects associated with insomnia. They include comorbidities such as anxiety, depression, substance use, and mild traumatic brain injury, and increased rates of insomnia, which increases depression. Insomnia actually predicts worse depression and worsened PTSD symptoms. The purpose of the study was to evaluate the effectiveness of CBTI delivered to veterans with insomnia at the VA Oakland Behavioral Health Clinic. This was a retrospective design using repeat measures of sleep efficiency scores to determine the relationships between the CBTI dose, or during the weekly sessions, and self-reported improvements in sleep. The setting was the Oakland VA Behavioral Health Clinic. They provide a full range of treatment, including drug and alcohol-related dependency treatment, medication management, methadone maintenance, individual and group therapy, and is run by the psychiatrist and psychiatric nurse practitioner. The participants who were included in this study all came from 2014 to 2018 cohorts. The inclusion criteria included a diagnosis and had already been treated for PTSD, and they had a complaint of moderate to severe insomnia. Exclusion criteria included those with a current substance abuse problem, any untreated PTSD or concurrent nightmares, sleep apnea or narcolepsy, along with restless leg syndrome or any circadian disorders. Our data collection consisted of demographic data including gender, race, ethnicity, age, and their combat status. We looked at CBTI dose, which was the independent variable, the number of CBTI sessions that were attained and participated in by the veterans. Some completed all 6 sessions, and some completed less than 3 sessions. We utilized the sleep efficiency score calculation derived from sleep diaries that were reviewed weekly. It was calculated using a weekly sleep efficiency score, and it's the ratio of hours of sleep spent to the actual time in bed, and is reported as a percentage, with an over 85% SES as a normal range. Our procedures: we started with CBTI flyers advertised at the clinic. We also instructed members to contact the psychiatric nurse practitioner or psychiatrist to enroll in the group, an intake assessment to ensure that the inclusion criteria was met, and then all members meeting the inclusion criteria and agreed to participate were enrolled in the CBTI group. CBTI procedures include number one, the psychoeducation. It's group therapy. It's 6 weeks. We have 4 to 6 participants per group. We teach sleep hygiene practices during the CBTI group therapy, including written handouts, explanation, and discussing during the sessions to explain any issues or answer any questions. The second component is individual sleep scheduling. We educate the participants on the process. We practice and report actual sleep and waking times to maximize the amount of sleep they're actually in bed. We also use sleep restriction therapy. We teach this during group sessions, explaining the premise and rationale for use. An example is going to bed a little bit later. They may feel less tired and wake up during the night less often. The third component of CBTI is progressive muscle relaxation. Actively engage participants in progressive muscle relaxation and mindful breathing during each group therapy. We used a combination of progressive muscle relaxation and breathing and exercise to reduce anxiety before the group started. Relaxation as a part of life balance was an essential component of therapy so that the participants could learn new coping mechanisms and help reduce anxiety and stress. And the fourth component is cognitive behavioral therapy, where we work on resolution of behavioral and emotional responses to insomnia and triggers the work that is occurring. Integrated insomnia relapse within the treatment cycle, and our participants who miss sessions could receive individualized sessions to catch up if they needed. And all 4 components were incorporated throughout each session. For the analysis, we used Intellectus Statistics 2018. We used descriptive analysis to complete and compare the sleep efficiency scores ranging from the baseline session 1 to sessions 3 through 6. The primary analysis utilized a paired t-test comparing SES. We did a Boniferroni adjustment and applied that to divide the alpha level by the number of analyses conducted by 5 for an adjusted alpha level of 0.01 to reduce the likelihood of a type 1 error. Here's the analysis of the paired t-test comparing sessions 1 to sessions 2 through 6. You can see that at session 2 compared to session 1, the mean SES was 73.72%, much lower than the 85% target rate for what we want for our sleep efficiency score. You can drop down comparing session 6 on the bottom, coming across the top, you can see 85.9 at the 6 sections. So people that completed all sessions actually achieved that 85%. We can see that I actually received 86.04% after session 5 and almost maximized their sleep efficiency score after that 4th session. For the results, our sample characteristics was a small population. We had 32 participants, including 28 males and 4 females. We did do repeated t-tests to compare each of the sessions. Our mean age was 34 to 90 years old with a mean age of 63.6. 50% of our participants were Caucasian and 88% were non-Hispanic. The majority of these veterans were non-combat veterans. So here's a table showing our results, breaking down the actual numbers who fit our demographic criteria. So the purpose was to evaluate the dose-related CBTI outcomes of the SES in our group for outpatient veterans. Our findings support improvement of the SES by the 3rd session by achieving a standardized treatment goal above 85% by after that 4th session. This is similar to a study population in the VA done by Talbot in San Francisco. They did an 8-week-long intervention and achieved a mean SES score of 78.7% at baseline. They measured again at mid-treatment with 91.1%, and they had a 93.7% point post-treatment effectiveness, which actually they did a follow-up and had a 6-month post-treatment sustainment. We had some recruitment challenges getting eligible veterans to participate, primarily due to the location, travel time, people work schedules, and we did have the group sessions on Tuesday mornings. Direct recruiting methods for research studies for CBTI at the VA required a higher level of effort than maybe some other indirect recruiting methods. Our mean attendance was 4.5 sessions with a standard deviation of 1.24 out of the 6. Some people missed sessions in between the first and final for a series of sessions at the end of the series. Some participants actually skipped sessions. They came to one, skipped a week, and then came to another. So there was a variety of data skewing. We did have a moderate retention rate for an outpatient therapy group. I looked at one meta-analysis that identified in 669 studies about 84,000 clients usually have about a 19.7% dropout rate. We did not collect data for reasons that participants attended or failed to attend sessions. There are possible several factors that created barriers to participation, so we focused on the data. Our groups met every Tuesday morning. Our participants working or traveling may have found time and expensive transportation prohibitive to attend. Some indicated forgetting or not remembering to complete their sleep diaries and thus did not attend this next session, and they would return 2 weeks later to be part of a catch-up session. One participant did, however, in the CBTI group show a 93% SES increase after the first 3 sessions, so she actually stopped participating and quit attending the group. Our study showed severe symptoms of depression, high levels of fatigue affected attendance. I had a dropout rate of 60% with an elevated depression system and a shorter total sleep time, according by a study by On-Call and Mamber, if they had less than 3.65 hours per sleep a night. We found that the total sleep times that were above 3.65 hours a night only had about a 9.3% dropout rate. So treating the insomnia early on and trying to educate that this does take some time for these veterans to get some benefit may help keep our retention rates up. All sessions at CBTI in this study were conducted face-to-face at the VA facility in Oakland. That being said, Internet CBTI may increase access and participation. We do have technology-based instruments such as the CBTI Coach, which was created by the Veterans Administration. It's a free app anybody can download. The Internet-delivered CBTI could be implemented, facilitating participation using a HIPAA-compliant privacy-style application similar to Skype, FaceTime, things like that that are available to be privacy compliant. Internet CBTI is an effective method for treatment delivery. We did examine 15 clinical trials and found that sleep efficiency scores improved by 7.2% above a 72% baseline after treatment. The insomnia severity index scores dropped 4.3 points, and the total sleep time increased by 20 minutes from 5.7 hours at baseline, which is a considerable amount if anybody's ever hit the snooze button. Our meta-analysis of 15 studies of internet-delivered CBTI had a number of 1,013. We had SES scores improved from a mean of 76.2 to 89.3% with this 95% confidence interval. One study indicated that face-to-face therapy actually may be preferred. However, internet-based CBTI may be more cost-effective than face-to-face group CBTI. Some of the factors is the age of the participant, lack of telemedicine knowledge, and those could be barriers to internet therapy for some patients. However, with laptops, cell phones, and other internet access devices, we can readily talk to people anywhere on the planet. So it would be the matter of training and developing programs to make these more effective. For discussion, we have some limitations. We had no control group. However, there is sufficient evidence in the literature to support CBTI as a preferred treatment for insomnia. This includes randomized controlled trials and systematic reviews, and treatment results of this study were also consistent with the current published research. There is evidence that supports insomnia can be worse for those who experience combat. I mentioned that since we didn't have a large combat veteran population in our study group. However, we have seen in Vietnam vets that has been much higher. So our measurements of sleep outcome, we're using SES. We use both the Pittsburgh Sleep Quality Index and the Insomnia Severity Index, allowing targeted interventions to address problem areas and to provide specific therapy to improve overall sleep. The PSQI measures sleep quality with factors such as things that cause difficulty of sleep, and a score of over 5 equaled poor sleep quality. Data collection of PSQI should continue to be used to individualize treatment during the CBTI program at the VA. Our subjective measurements were done with the Insomnia Severity Index. This measures difficulty falling asleep, difficulty staying asleep, people that awake too early, and any impact on their daily activity, such as noticing any sleep issues and not being satisfied with the sleep that they are getting, or actually worrying about sleep problems and having them on their mind. Any score greater than 15 would indicate clinical insomnia. We recommended this as one measure of sleep outcomes. The ISI has excellent internal consistency with a Cronbach's alpha of 0.074 and a temporal stability of R being 0.80. We validated and compared this with sleep diary data, and we found it's very sensitive to changes in perceptions of sleep problems. There was no direct cost for this project. The CBTI groups are an ongoing intervention with the VA. Side note for public health, as this is part of a regular VA program, getting insurance companies to pay for this type of thing would be something that would have to be evaluated in a future study to provide sources of income and payment for people, as it is very beneficial. So our conclusions: the DNP essentials were met with scientific underpinnings of practice, the organizational systems leadership working with the clientele and the people at the VA, the psychiatrists, the support staff, etc. Utilized clinical scholarship and analytical methods for evidence-based practice, used IT technology, accessing the computer system there, and reviewing data along with Intellectus statistical software, and of course our healthcare policy advocacy and healthcare to improve access to care, interprofessional collaboration, and improving patient and population health cares by working with the staff was done. We use clinical prevention and population health by encouraging members to participate in group and just having discussions even in the lobby, talking about ways that they may improve their lifestyle, their sleep hygiene, where they're sleeping, do they have a pillow, do they have a place to sleep, are they homeless, etc. Using the advanced practice nursing role, I was able to use opportunities to address concerns in that veteran population with multiple comorbidities and disease process across their lifespan. Some of my key takeaway points is the treatment of insomnia with at least 4 sessions of CBTI improves the sleep efficiency score, and we hope to reduce depression and suicide by correcting the underlying problem of insomnia. And the implication for practice is utilizing that non-pharmacological intervention as a low-cost way to reduce that loss of life. The VA system provides this care, and as I said, the civilian sector needs to find a way for any reimbursements for that. I'd like to acknowledge Jacqueline Raines from the Department of Veteran Affairs, RNNP. She's been my practice mentor since February 2018. Greg Rousset I started with in June of 2017 working on this program since he moved to the San Francisco VA. Dr. Kate Shade participated in my technical editing of manuscript last year. James Lonnie from Intellectus, and Demir Sarek, instructor and research analyst, who was my statistical support earlier this year. Thank you so much, and at this time I'd like to see if there's any questions that I can answer for you.